Hello from Williamson Health. My name is Michelle Simpson. Thank you for joining us for this episode of Health Talks from the Inside Out. So Dr. Jared Slater, I want to welcome you to Health Matters from the Inside Out, our new podcast, and you are one of our very first. So Thank you for being here with us today, being one of our guinea pigs. The whole idea is just to have a conversation, keeping the patients in mind. We're wanting to help educate them on the things we do around here and how you could potentially help them through some issues they might be dealing with. So welcome. We're glad to have you.
Well, thanks for having me. I'm glad to be here.
Yeah.
So you are a surgeon with Williamson Health Medical Group.
Yes.
How long have you been with the practice?
Just over 2 years.
Yes.
But I've been a surgeon for a long
I was going to say,
longer.
So where were you before this?
So I came from Minnesota originally, and we did a brief stint in Florida for about 11 months.
Okay, very brief, yeah.
Couldn't handle the heat.
Okay.
But my wife's dream was always to be here in Franklin.
Okay.
So when she saw the job posting, she actually sent it to me and said, "This is where we have to be."
I got it.
And ever since we've been here, we've realized that she was right.
Yes. And you said yes, ma'am.
Were we surprised? Yeah,
Yes.
we were not.
Very happy to be here.
How did you get into medicine? How did you end up choosing your specialty?
So when I was a freshman in high school, I had appendicitis. My parents didn't believe me.
Yeah.
They made me play a basketball game that night.
Yeah.
Oh no.
And I kept feeling all this pain, and so finally we went to the hospital, and the surgeon said, "You have appendicitis, we have to go to the operating room." And I was one of the first laparoscopic appendectomies in Minnesota.
Yeah.
So after I woke up, the papers were there, everyone wanted to talk about what we did. I had no idea what was going on.
Right.
But I thought it was so cool that I was in so much pain, and the surgeon came in and just fixed me.
Yeah.
At that point, I told my parents, "I want to be a surgeon."
Wow.
They're like, "No, you don't." But it never left. That's was always my goal. So I called the surgeon who had taken out my appendix and said, "Could I start shadowing you?"
Yeah.
So I started shadowing him in high school, and then when I got my license, I would actually drive him around to the local hospitals at night so he could sleep. Then he let me scrub in the case with him.
Oh, wow.
So I
that's
started
so cool.
seeing the operating room really at an early age. So
From the guy that did surgery on you, which
From
I
the
think
guy
is
who
just
did
so
surgery.
cool.
that desire, I guess, never left, and so here I am now taking out appies. And every time I have a patient in the ER with an appendicitis, I tell them that this is why I got into this.
Yeah.
So it's fun to be able to help them. It's kind of a full circle moment.
And what is general surgery? Because I feel like it's seems like a broad term. So what kind of conditions do you treat?
Yeah. So general surgery really encompasses everything except, brain, heart. We're kind of acute care surgeons also, so we handle anything that comes into the ER that's probably soft tissue.
Okay.
One year I heard I think my daughter was 10 at the time, and someone said, "What kind of surgeon is your dad?" And she said, "Oh, he's a soft tissue surgeon." I thought, how did you know that?
Yeah, and we do talk about that, but what does that actually mean? Soft tissue.
Unlike an orthopedic surgeon who does, bones, joints, that kind of thing, we do more soft tissue things, skin cancers, breast cancer, colon cancer, really anything within the GI tract, some lung or chest surgery, but not as typical.
Okay.
A lot of hernias, gallbladders, bowel obstructions, a lot of things that would come to the emergency room that involves the GI tract. So more soft tissue stuff, whereas the orthopedic guys are really the bone guys.
Right. So you talked about your personal experience with appendectomy. I have the same. When I was 15, my appendix ruptured as well. What is the appendix? Why do we have it? And why is it okay if we live without it?
So we're not quite sure why we have it.
Yeah.
But the appendix doesn't have a function that's critical to life.
Okay.
Some people are looking at, does it play a role in our GI tract? We're not quite sure about that. But people can do fine without it. We're living proof.
Yep.
So,
Yeah.
do you have your appendix?
Yeah, I had a fun little surprise appendectomy a couple years ago.
So all
none
three
of
of us,
us.
we are missing our,
Yeah.
So the cool thing to do is get your appendix out.
apparently.
Yeah.
Yeah.
Well, my pain had started in my stomach.
Yeah.
Not, how they say the right side pain is the
Yeah.
appendix pain. Mine was in the middle of my stomach, which I guess that's where it can originate, which I'd never heard, so I didn't know that's what it was.
Right.
So for hours, I'm just like, oh my gosh, I thought I was getting a stomach virus.
Yeah.
But
Yeah.
it was appendix.
It usually will start around the belly button.
Yeah.
And that's the initial presentation, and then it'll start to migrate down to the right lower
Okay.
quadrant. So our ER team is well versed in
Okay.
diagnosing appendicitis.
Oh yeah,
It's
as soon as
very
I came
common.
in, he was like, yeah.
Yeah.
He was
they
like,
know.
oh yeah, probably appendicitis. I was like, but it's not over here. He's like,
Yeah.
yeah, it's
Yeah.
fine. That's
pretty classic presentations, so it's usually pretty easy for us to diagnose that.
Right. Okay.
But patients do very well with that surgery. It's usually laparoscopic.
Okay.
It can take anywhere from 8 to 30 minutes.
Like 8 minutes
Yes.
surgery?
Wow.
Because we do them all the time.
Yeah.
So anything that you do all the time,
Yeah.
you should be good at.
Right.
And that would be everyone in my group.
And is it an outpatient, or people going home the next day, or sometimes they stay
It
overnight?
varies.
Okay.
So like for you and me, we had a ruptured appendix.
Right.
Was yours ruptured?
No.
So you
and then I got peritonitis.
yeah.
Yeah.
So those
Is that the
patients
name
will-
of the infection?
Yeah,
Okay.
so that irritates the lining of the
Yeah.
abdominal wall.
Yeah.
We say it's peritonitis.
Okay.
But if someone has an abscess or a perforation, then typically that buys them a few days in the hospital
Okay.
for some IV antibiotics.
Right. Okay.
But if it's non-perforated or there's no abscess, we can do the surgery and that patient can go home the same day.
Okay. Great.
And the incisions were so small. Like,
Yes.
I couldn't get over how tiny that they were. Like, I know the inside, like behind that, you've obviously cut, but like just the incisions themselves were so tiny,
Right.
which just speaks to how far surgery
Yes.
has come.
Right.
So
Yeah.
I know you're doing a lot of minimally invasive stuff, which kind of falls into like you've got a robotic area and then you've got a laparoscopic area. Can you explain kind of
Yeah.
the difference between the two and what most of your procedures are?
Sure. So I think everyone in my group, we're all about the same age, and we all train probably open and laparoscopic. So that was kind of our bread and butter. But then the robot came, and that just elevated, the things that we can do surgically in a minimally invasive way to the next level. But a lot of what we try to do is laparoscopic. And to your point, people do worry about a scar in their abdomen or scar anywhere, and we can really hide those well. So most patients won't really have anything obvious that they had surgery.
Right.
So with kids, women especially, I'll try hide those scars in the belly button and then in the bikini line, so that someone's at the beach for the summer, no one would know, oh wow, they had their appendix out.
Right.
But we can usually get by with very small incisions for most of our intra-abdominal cases. But the robotic surgery took it to the next level. So we can do big colon resections where we used to open somebody up from their xiphoid down to their pubis, and now we can do it through 4 little incisions, and patients can sometimes go home the next day.
That's incredible. So what other benefits are there? Because there's a lot of benefits to minimally
Yeah.
invasive surgery.
So, big benefits are less pain, less bleeding, better visualization, quicker return to your normal life,
Okay.
less hospital stay. So, I think when people hear the word surgery, everyone gets scared.
Right.
I always joke, no one wants to see me. But sometimes when you're in that critical situation or you're feeling terrible in the ER, they are excited to see us because we have an answer for them and we can make them feel better. And that's what impressed me as a kid.
Yeah.
Was, we've all had it, to be in that much pain and then you wake up and it's
Right.
better.
Wow.
Gone.
That's amazing, I think.
Yeah. So we talk about robots a lot in
Yeah.
surgery, robotic surgery. It's really robotic assisted surgery,
Yes.
correct? So
Yes.
talk us through that process a little bit. The surgeon is still actually performing the surgery. You
Yes.
are in control.
Yeah.
The robot is just
It's a tool.
assisting. It's a tool.
It's an instrument that we use to be better.
Right.
So I think when the robot first came out, I was trying to get patients to do it,
Yeah.
and they'd say, no, I want a human doing
Right,
the
right,
operation.
right.
And I think the concept was that someone like R2-D2 came in
Right.
and did the case while I was having
Like
coffee.
off in the
Right.
lounge,
Right.
yeah, sipping your
Exactly.
coffee.
But that's not the case. So laparoscopic surgery, it was straight sticks. We did not have much range of motion. So for us to operate, we were in a limited plane and couldn't do much.
Okay.
The robot mimics the motions that we use. So it has a wristed motion, it can turn, we can suture in the abdomen in a very tight, small space. So the things that we can do are broadened. So the nice thing with robotic surgery is I'm in the room, I'm watching the team, and I'm on the robot. I have a 3D representation of what's inside the abdomen with a better, I guess, range of motion of things that we can do.
Wow.
That's incredible.
Yeah, it is.
So you mentioned that when you were in med school and doing your training, robots really hadn't taken
I think they
on
had
yet.
started.
Right.
When I look at the history of Intuitive, which is the company that has the
Right.
robot that's out, they were starting to develop some things more for field surgery,
Okay.
for military.
Oh, okay.
Because I thought if we could go into the field and help somebody without the doctor on the field, putting
Right.
their life at risk, that was kind of the concept
Right.
at first.
That's cool.
But as it got further along in the development, we realized it could really be utilized
Yeah.
everywhere for
Yeah.
patient care.
Yeah.
Like I'll tell patients, the robot actually checks itself, I think it's like 1,800 times a second. So if there's any tremor or any movement that you don't want, the robot smooths that out. But our visualization is so good, we can see really anywhere in the abdomen.
Yeah. And I guess that's just a standard part of surgical training these days,
Now
right?
it is.
Everybody is now learning.
I think everyone has robotic experience. And the residents who are coming out of residency are robotically trained as part of their training. Where all of us had to get certified and take courses. But that's probably a main part of how we operate here at Williamson Health.
And there's a lot of specialties that can use the robot, because we've got the 𝐷aVinci Xi, right? We've got 2 of those. And there's multiple specialties that can use it, so it's not just general surgery. There's several others that get to utilize it too.
Gynecology uses it, urology, general surgery, obviously, and all the specialties of general surgery, like colorectal, endocrine. So it has a lot of function within the operating room.
Yeah. So we've talked about robotic assisted surgery, we've talked about laparoscopic surgery, but are there still cases where you might need to do what you call an open cut, which would be a larger, and so talk to us about that.
So when a patient comes, let's say, to the ER or to our clinic, it's really a team effort of how we're going to approach a patient's care. My job is to look at all the data, imaging, labs, my physical exam on a patient, and then talk the patient through what their options are. And I always tell my patients, we're a team in this. So I want to know what your goals are. This is what I think is right for you. But we have to listen to each other and come together for the right thing for a patient. Sometimes when somebody comes to the ER with a perforated bowel, where there's contamination in the abdomen, or the bowel is very distended, sometimes minimally invasive surgery isn't the safest option. So we still have to open things up. I think most of us will always try laparoscopic surgery. We'll put a camera in, see what's going on. And then at that point, we have to decide what's the right thing for the patient. So I always tell my patients, if you trust me to put you to sleep, I take that responsibility very seriously. And I will only do what's the best thing for you to do well. So I think at that moment, when we're in an abdomen, or trying to figure out what's the best thing for a patient, I'm always thinking in the back of my mind, this patient's trusting us to do the right thing. We have to take that seriously.
What percentage of open do you do versus minimally invasive?
So I do some breast surgery, and so that's always open. But anything within the abdomen, I think we can always try it laparoscopically, except for some of the small belly button hernias. Sometimes if a patient's not a great candidate for a general anesthetic, we can do a groin hernia open, because they don't have to have the same sedation. But otherwise, most of us try everything minimally invasive. And usually it's robotic.
So let's talk about hernias. What is a hernia? I know there's different types.
So a hernia is really just a bulge or a defect in the abdominal wall somewhere. Typically what we hear about are groin hernias, probably more common in men than women, but both men and women get hernias. They can be congenital. They can develop from weightlifting or strenuous activity. Some patients who smoke or on steroids may have weakening of the abdominal wall. But really it's a breach or a hole in the strength layer of the abdominal wall. We can see them at the belly button, we can see them at the groin, and we can also see them anywhere there's been a previous incision. So if somebody's had, let's say, prostate surgery, and they need to have an incision to take that prostate out. When they sew it up, there's always a risk, for any incision, that it could break down and cause a hole where bowel could come through and get stuck. So that poses a risk for bowel obstruction. So that's when we say we probably need to fix this.
So hernia, when do you know when you need to see somebody about a hernia? Because like my husband's had one for, it's probably been 20 years now. It was a high school weightlifting injury, but it doesn't bother him. He's like, I don't want to go get surgery unless I have to. Is that kind of the attitude of most of your patients? Like when do they really need to come in and be like, okay, we got to figure this out?
So I always tell patients, once it's affecting your daily activity, I'd probably get it fixed. But there are a couple things I always consider when someone's looking at surgery. One, cosmetically, is it bothering somebody? I think a lot of people, if they're wearing a shirt and see a big bulge, that's upsetting. Usually it's the wife will say, you need to go get that fixed. Because the husband's usually like, I'm probably good. So I see a lot of men who will come in and say, I don't want to be here. I'm here for her. But I think once you're starting to notice something's wrong, you need to probably see somebody and at least establish care so you know if this is a problem, who can I see to get this fixed? And establish that rapport and that trust. But a small hernia worries me more than a big hernia. Because if you have a small hernia and you cough or bear down or go to bench press something heavy, bowel can get in there and get stuck.
Okay.
And if that bowel gets stuck, it could die. And then it becomes more of an emergency.
Oh.
Whereas a large hernia, things can move in and out probably a little easier. So those don't always worry me as much.
Okay.
How do you know if you have a
That's
small
interesting.
hernia? Because
Yeah.
I feel like a big hernia, like you know, because
Yeah.
it's a big old like golf ball.
Yeah.
But
A lot of people will notice, a little bulge or maybe some discomfort.
okay.
Sometimes the first symptom of something will be just like a burning sensation by the thigh or the side of the scrotum. Patients will notice just a change.
Right.
But most patients will say, I feel a bump or I feel a little bit of pain.
Right.
And I think at that point you're always welcome to come see a surgeon. We'll never force you to have a surgery, but we'll walk you through, what the surgery would be, what the risks are, what the
Right.
benefits are. A rule of thumb for me is you should never be aware of a body part. So
Okay. Yeah.
if you're living your
That's
life,
That's a
Good
good
point.
yeah, everything feels fine, you're probably okay. You should still do your yearly exam with
Right,
your doctor
right,
because
of
they'll
course.
find stuff
Yeah.
like that. And that's why preventative health is good. But once you're aware of a body part and it's affecting you so that you can't live your normal life, well then let's fix it.
Right.
Because we can get you back, like for your husband,
Yeah.
if he ever wants to have it fixed, we could get him back to his normal life pretty quick
Right.
without the risk of a bowel obstruction.
Right.
I also say if you're traveling a lot, like a lot of retirees, they're doing all these great trips. I'd hate for them to have a problem on vacation
Oh, yeah.
or out of the country.
Yep.
So if someone fits that profile, we should probably do
Take
something
care of it before you
electively
Yeah.
Oh,
at
that's-
their home.
So diverticulitis.
Yes.
Talk to us. What is that? What are the treatment options for it?
Yeah. So diverticulitis is the inflammation part of diverticulosis. So as we age with our Western diet
Okay.
and genetics, we start to get these little outpouchings in the colon wall. So the colon should be a long, smooth tube.
Okay.
Where the blood vessels penetrate the bowel wall, it creates a natural weakening. So it's almost like a hernia of the colon.
Okay.
The most common spot is the sigmoid colon, which is down in this left lower quadrant. So typically patients will know, they'll know they have a family history. They'll say, oh yeah, my dad had diverticulitis, or I always have heard people talk about that. It's usually diagnosed at a colonoscopy. So as long as people are getting them routinely,
Okay.
they know that they're at risk for it.
Okay.
I always heard it was very painful. So you're saying that people may not even know that they have it and
Yeah.
go in for like a colonoscopy and it's like surprise.
Well, so diverticulitis is painful.
Okay.
Diverticulosis
Is not- okay.
is like a silent
Silent.
issue.
Oh.
Yeah. So sometimes patients will present with a GI bleed, and anytime someone sees blood in the stool or on the toilet paper, it's concerning.
Panic,
Yep,
yeah.
people
Yeah.
will panic. But it can just be bleeding from that blood vessel from irritation or maybe a seed or stool getting stuck in one of those little holes.
Okay.
It's not a true hole, it's like a hernia.
Yeah.
But once something obstructs that little opening, it can perforate, and then things from inside the colon can leak out into the abdomen, and that causes diverticulitis.
Wow. Okay.
So there's two ways to think of it. You can have acute diverticulitis, where you have inflammation of the colon, and that can just be treated with antibiotics. But once it's perforated or you have an abscess, then we
To
get
repair
involved.
it. Yeah.
So sometimes it could be as simple as a little drain. Our colleagues here in interventional radiology are awesome because they can put a drain into almost anything.
Wow.
So people could come in with an abscess, IR goes in, they use a CT scan, and they find where that little abscess is, put a drain in there, and that usually resolves the issue.
Okay.
When I was training, if you had diverticulitis, you went to the operating room, and you'd
Yeah.
usually end up with a colostomy bag, which is probably everyone's big fear.
Yes. Yeah.
Oh.
So my wife, when I first told her that was something that could happen, she was like, "Wait, that could happen to a
Right.
human?
Right.
You're not unaware of it." So I think that's people's fear.
Yeah.
So it's a good reason to start your colonoscopies at the age of 45. Know what's going on, and if you ever develop that left lower quadrant pain, if you can get started on antibiotics quickly, that's probably all you'll have. It's just a little bit of pain and then a quick recovery. But once it becomes complicated, infected, or an abscess, sometimes we have to operate. And we go in and take out that diseased portion of the colon. And if it's emergent, we haven't had a bowel prep, patients end up with a colostomy. So that's where you stool into a bag temporarily.
Right.
and then a few weeks to months later we can reconnect them.
Okay.
But the ideal is to get them through that acute episode with either a drain or antibiotics, so we can go back electively, take out that portion of the colon, and sew it back together at the same time.
Wow.
So that'd be the goal. But it's a very common thing that we see in the ER, and I think everyone's fear is having that bag. So we try.
I didn't know it was like reversible, I guess,
Yes.
in a lot of cases, because it sounds like most people, you do get off of it eventually.
Yeah. So the goal is to reverse it.
Yeah.
There could be some special circumstances where it's difficult, and we can always use colorectal surgery as someone that we can send somebody to for a very complicated case. But for the most part, we manage those here all the time here at Williamson Health.
So it's more common than we
It's very
probably
common.
realize.
Yeah. For us, it's an everyday occurrence.
Wow.
But for a patient, when they come in, that's the first time they've seen it.
Right.
We realize this is scary, and we do everything we can to work with the patient to come up with a plan that they're comfortable with to get them through it the least invasive way possible.
Right.
Well, I had never heard diverticulosis until today.
Yeah.
I heard of diverticulitis.
Yeah.
I never heard diverticulosis. So
Right.
I learned something
That's
new
great.
today.
Yeah.
So there's the
I know we
normal
learn
colon.
something every day.
There's diverticulosis, which is non-painful typically, and then diverticulitis, where you have that inflammation that probably requires treatment.
The more you know.
Wow.
The more you know.
Wow.
What is the most rewarding part of your job?
Boy, there's so many rewarding things. I think seeing somebody come in with pain and watching them leave feeling better is very rewarding. One of my favorites is just the other day I had a patient with a bad breast cancer, and she had to do upfront treatment with chemo and radiation.
Okay.
And you can just see that people are stressed, hoping and praying that this chemo is targeting their tumor and doing something. And we did an MRI just to see where she was at after her first cycle of what we call neoadjuvant treatment. And the tumor had completely disappeared.
Vanished. Oh my God.
And so to be able to tell her everything that you just went through, which I know was scary and difficult,
Was worth it because it's
was
gone.
worth it
Oh my
because we
gosh.
don't see any tumor.
Yeah.
And then to go back in and take out that residual tumor and tell them you have no disease.
Yeah.
And just to see that weight off of somebody's shoulders and to reassure them like you're going to be okay, I think that's what makes it all worth it.
Oh, yeah. That's amazing.
Wow. So how can patients find you or one of your partners?
So we're located here at Williamson Health in the tower.
Okay.
I'm up on the 5th floor. You can find us online, or you can get a referral from your primary care provider. We're really happy to see anybody. So if a primary doctor doesn't even know where do I send this patient, they can always send them to us. And if we don't treat that, we'll find one of our partners who does, or we can refer them to the right person. So sometimes that just makes it easier to refer so we can handle the problem and address it however it needs to be. But I'd say look online, talk to your primary care provider, or just come up to our office and figure out how you can be seen. We're happy to see anybody.
Yeah.
Well, thank you
great.
so much for being with us today. I feel like I definitely learned
Yes.
a lot.
Yes. It's been
Wonderful.
great.
We greatly appreciate it, and thank you for all you do to help serve our patients.
Well, thank you for the time. It was fun to be here today.